Hi, my name is Michaela Jackson, and I am the Prevention Policy Manager for the Hepatitis B Foundation. And you guys are here today because we are starting and kicking off the Viral Hepatitis Policy and Advocacy Summit that is hosted by the Hepatitis Appropriations Partnership. So, just to give a little bit of background, for those who might not be familiar, the Hepatitis Appropriations Partnership is a nationwide coalition that's based in DC, and we are basically representing the viral hepatitis community and their advocacy needs for the community and any resources that they might need in order to help improve the rates of testing and prevention in the viral hepatitis community and making sure that people are receiving the resources and care that they need on the ground. So today we're hoping to have a robust interactive discussion. So just a few housekeeping before we get started. First, all attendees are on mute as they join. So you can be able to speak during the Q&A portion if you want to. If not, you can just enter your questions into the chat box or the Q&A box. Going on to the chat, please feel free. We have a few poll questions. If you have any thoughts that pop into your head, anything that you want to respond to, just drop it in the chat and we'll be sure to check that regularly. And any questions, just pop it in the Q&A box and we'll get to it during the Q&A portion. So getting started with the agenda, we have a really great panel for you. They're going to do some presentations to do a little bit of background and information about health equity and viral hepatitis. Then we're going to have a really rounded, robust discussion, and we're hoping that you guys will be a part of that. So again, please drop any questions that you may have into the box, and we will go ahead and answer them. So to kick us off, we just wanted to start with a broad poll question to kind of get us thinking about what we might need heading into this appropriation season and heading into this policy and advocacy summit. So the question is, aside from those present today, what other federal agencies or divisions of federal agencies would we like to see be more engaged in addressing any issues related to viral hepatitis? And so let me go ahead and launch that poll. And again, you guys can feel free to drop any information in the chat. And just so you guys know, today we have the Office of Minority Health on the line, and we have the Office of Infectious Diseases and HIV/AIDS Policy with us from the federal perspectives. And so this is just a really great question to kind of get us thinking, as we know viral hepatitis encompasses a lot. There's a lot of different federal agencies and divisions that have work that are related to viral hepatitis, but we might not be as engaged with some of them as we might want to be. So I see a lot of you answering right now. Oh, is this a different poll? Sorry, wrong poll. All right. Well, this one is, within your communities, what is the most common barrier to getting tested for hepatitis B and/or hepatitis C? So I will go ahead and end that poll. And it looks like right now we have health insurance coverage and the cost of services being one of the main barriers with 39%. Hepatitis-related stigma being the second one, which is great. We're going to talk about stigma today. And then followed by transportation and language. So those are the results. And now we're going to go ahead and turn it over to our first panelist of the day.
Hi, good afternoon, everyone. Thank you so much for inviting me to talk about this really important subject of viral hepatitis and health equity. I'm Jessica Deeren. I'm a viral hepatitis policy advisor with the Office of Infectious Disease and HIV/AIDS Policy. So I want to first start off by saying that this is a priority area for our office as we continue to look for ways to advance health equity across all of our work, as well as within viral hepatitis. So I'll start by providing an overview of some of the work we are doing in this space. Next slide. So as many of you know, my office coordinated the development of the Viral Hepatitis National Strategic Plan, which was released in January 2021 And this is a roadmap for all stakeholders to work collectively so that we can reach viral hepatitis elimination by 2030. There are a number of key points that advance health equity in the strategic plan that I'd like to highlight. We added a goal to improve viral hepatitis surveillance. So improving surveillance data will allow us to better address and improve opportunities for health equity by further identifying health disparities and disaggregating populations at higher risk for infection or mortality. Another key highlight from the plan is supporting a no wrong door or syndemic approach. We recognize the intersections and synergies across the epidemics of viral hepatitis, HIV, STIs, and the substance use epidemic. And we also recognize the contribution of mental illness, stigma, discrimination, and social determinants of health to the viral hepatitis epidemic. Thus, the plan calls for an integration of services across all of these areas, integrating prevention, screening, and care and treatment among all components of this endemic. The plan also has a focus on addressing health disparities and eliminating health inequities, which will be described in more detail on the next slide. Next slide. So goal 3 of the plan addresses viral hepatitis disparities and health inequities. The bullets listed here are the high-level objectives from the plan, in which we hope all stakeholders will have a role in, but I'll go into more detail of some areas our office is working to address these issues. To reduce stigma and discrimination, our office worked with HHS's Office for Civil Rights to release a joint letter, raising awareness that there are federal laws prohibiting discrimination on the basis of disability, including people with hepatitis B. Unfortunately, there are still discriminatory practices occurring against people with hepatitis B within health education programs and delivery sites. So we encourage all health professional schools to review their policies. As many of you know, we now have universal recommendations for hepatitis C screening and soon to be universal recommendations for hepatitis B vaccination for adults through age 59. These universal recommendations can reduce stigma associated with risk-based screening and risk-based vaccination recommendations. It can reduce the need for providers to assess stigmatizing risk factors and increase opportunities for screening and vaccination for all. To raise awareness of the new vaccination recommendation, our office is coordinating a webinar with federal partner agencies to share implementation strategies. And this will be held in May, so stay tuned for a registration announcement on the webinar. Since the strategic plan was released, our office has been busy preparing the federal implementation plan, which outlines activities federal agencies commit to in order to achieve the goals outlined in the strategic plan. And the implementation plan is a way to ensure accountability and to facilitate collaboration. And we hope to release this soon. It is currently going through HHS review. Following the release of the implementation plan, we will develop progress reports, which will provide updates on how the nation is doing and meeting indicators, including disparity indicators. In the strategic plan, we included a list of indicators to measure how we are doing in terms of incidence, awareness, and mortality stratified by these priority populations listed here. And identifying the problem through data is the first step to really help raise awareness of any disparities to allow us to provide opportunities to advance health equity. Next slide. As mentioned previously, our office is working towards a coordinated approach across the federal government to integrate services across this endemic of viral hepatitis, HIV, STI, SUDs, and intersecting social determinants of health. We are planning our kickoff Syndemic Steering Committee in early April, in which federal agency partners working across these disease areas will meet and collaborate to discuss our syndemic approach. And we include agencies that not only work in these disease areas, but also address social determinants of health, recognizing that this work will require an intersectional approach. Next slide. So this slide summarizes other areas our office is working on to address health equity. To begin with, I want to emphasize that health equity is a priority within HHS leadership. The Office of the Assistant Secretary for Health, in which OIDP sits, has even developed a new office focusing on health equity. It's called the Office of Climate Change and Health Equity. And just this morning, we were in an office-wide meeting and we're reminded to keep health equity in mind in all of the work that we do. My office also has a project in which we are addressing payment and reimbursement barriers to integrated viral hepatitis services in clinical and non-clinical settings. So it's good to see that poll question, which the #1 answer was payment issues and insurance coverage. So this is something that we're working on. Next steps is we're conducting focus groups in which we are reaching out to different states and regions to gain a representative perspective on the barriers and assessing how federal agencies can address these issues to really provide more opportunity for healthcare access and viral hepatitis services for all. OIDP has an important coordinating role of working across federal partners and community members to identify areas of collaboration to address all components of this endemic, to identify opportunities to advance our work collectively. Throughout development of the strategic plan and implementation plan, we received public comment, which really does inform our work. And we want to thank many of you for providing your input and having ongoing conversations during development of these plans, as well as through routine meetings that we have with stakeholders to hear about issues occurring on the ground. And we welcome continuing conversation on how our office can support advancing health equity in the communities you serve. We also provide transparency in how the federal government is meeting the goals of the National Strategic Plan, including in addressing health inequity. And finally, we work closely with the Office of Minority Health and their Hepatitis B Demonstration project, which I know our next speaker, Lieutenant Commander Martin Braswell, will go into more detail next. But in short, this project provides additional services for populations disproportionately impacted by hepatitis B. Next slide. So that concludes my presentation. Thank you for your time, and I look forward to the discussion later.
Hi, good afternoon, everyone. My name is Lieutenant Commander Lucy Martin Braswell, and I am the project officer for the Hepatitis B Demonstration Grant in the Office of Minority Health. The Office of Minority Health is dedicated to improving the health of racial and ethnic minority populations through the development of health policies and programs that will help eliminate health disparities. I am so thrilled to be here today and be a part of the conversation on health equity and hepatitis in the context of the Hepatitis B Grant Project. Next slide. The OMH Hepatitis B Demonstration Program was launched as a 3-year initiative in July of 2019. The initiative is in the final months of the project period, which is slated to end June 30th of this year. The Office of Minority Health funded 5 organizations that are focused on strategic partnerships that will lead to the identification and development of model comprehensive hepatitis B programs that have the capacity to deliver widespread vaccination, scale up testing, linkage to care, and treatment services. Partnerships include community-based organizations, servicing communities with a higher burden of hepatitis B, health departments, perinatal hepatitis B programs, safety net providers, academia and research centers, and healthcare facilities. The populations of focus for the hepatitis B grant are persons in countries with a high prevalence of hepatitis B infection, greater than 2%, and really focusing in on African and Asian immigrants. We're also looking at all pregnant women during the first trimester of pregnancy, US-born persons not vaccinated as infants whose parents were born in countries with very high prevalence of hepatitis B infection, household contacts or sexual partners of persons with hepatitis B infection, perinatal, child, adolescent vaccination, and adults who may be at higher risk for, again, Hep B infection. This project has been a wonderful partnership between federal agencies where OMH is in consultation with the Centers for Disease Control of Viral Hepatitis. And I want to give a shout out to Dr. Erin Connors with the Division of Viral Hepatitis, as well as the Office of HIV/AIDS and Infectious Disease Policy. And again, with Jessica Deeren, Dr. Jessica Deeren, who's also one of our panelists today. And so working together with our awardees in this federal partnership to support the advancement of the grant program. Thank you. Next slide. The initiative encourages the strategic actions recommended by the National Academies of Sciences, Engineering, and Medicine. This initiative expects funded projects to encourage adherence to established Hep B recommendations for screening, vaccination, management, and treatment of perinatal and adult Hep B prevention. There's also a focus, again, on maximizing reach of patients and building the capacity of providers to reach the focus populations. We're also building the capacity of those community-based organizations, as well as those healthcare facilities to, again, screen, vaccinate, and link patients to care in populations that, again, are at a higher risk for hepatitis B infection. We're also monitoring viral hepatitis-associated health disparities, transmission and disease, advancing translational and implementation projects to improve understanding of viral hepatitis and disparities, and encouraging the participation of community members and collecting those lived experiences as part of this initiative and disseminating those findings and successful strategies. Next slide, please. Thank you. So I'm going to share some preliminary data that has helped inform our efforts in the first 2 years of the project. Again, we're in the last year, and so data that I will be, preliminary data that I'll be sharing today is, again, helping with us highlighting the health equity approach that these wonderful projects have been engaged in. I want to uplift that the implementation of this project has been throughout the pandemic, and despite the COVID-19 pandemic, awardees collectively increased testing from year 1 to year 2 by 13%. At the end of year 1, awardees anticipated a decrease in testing for hepatitis B, but due to the COVID-19 pandemic, but through a series of innovative pivots and adaptations, I commend this group. The program was able to increase overall testing. We did observe an overall increase in screening across the focus groups, with the exception of African immigrants. And that allowed us, again, to pause and think a little bit about the approaches that the projects were taking. Next slide. Well, thank you. One thing that was also observed in year 1 of this project was that we observed racial disparity among African immigrants in their linked and engaged and retention and care. These pauses to look at the available data and reflect on the priorities for the upcoming year were really important, as the group wanted to be more intentional about their focus and focus their efforts in year 2 to address this initial disparity that was seen. Next slide. As we close out year 2, we paused again to look at the data to see if we had made progress to close the disparity gap we found in year 1. We were really pleasantly surprised and encouraged that although the testing for African immigrants dropped, we saw the efforts in year 1 to help with closing the disparity gap of linking positive cases found within the African immigrant population that were being serviced to care were improved. Next slide. To wrap up my update on the OMH Hepatitis B Demonstration Grant, I want to highlight a few activities that awardees were engaged in that we have observed as fundamental to advancing equity. Again, I want to emphasize that it's not just one activity, but the systematic approach that these 5 awardees have really taken throughout the project period, with a special focus on equity. One was partner capacity building. So not just having a partnership, but giving those partners the tools, as well as building their capacity to engage in this work. COVID-19, although interrupted some of the in-person activities planned around screening, it did bring to light stigma early on that were experienced by the Asian population. And it was an opportunity to really enhance the education and awareness, not only on COVID-19, but also hepatitis B. It also presented opportunities to speed up innovation around the use of telehealth and hybrid screening models. Third was culturally and linguistically services and approaches. These have been really instrumental to ensuring the programs are tailored to resonate with the communities and populations of focus, as well as ensuring the projects are able to maximize reach. And last but not least, others have also mentioned through your questions, as well as Jessica mentions costs, right? So this has also been a theme around equity. The cost for treatment and medication continues to be reported as barriers to care, and one that that needs attention and support. And this is something that has also been a theme with the OMH Hepatitis B projects. Next slide. Thank you for listening, and you may reach me with any questions about OMH Hepatitis B grant. I'll be happy to connect you with the wonderful awardees that have been deeply engaged in the work if you're not already connected with them. Thank you.
Hi, everybody. My name is Sue Wong. I am the medical director for viral hepatitis programs in the Center for Asian Health at St. Barnabas Medical Center in New Jersey. I'm also chair of the New Jersey Hepatitis Coalition and past president of the World Hepatitis Alliance, which is a nonprofit NGO that represents patients and believe that patients should be at the heart of driving hepatitis elimination. So first off, I want to thank the organizers for having me here. This is such a great session, and I'm glad we're doing this, and glad to see such a great audience. And I'll be focused on talking about hepatitis B in Asian American communities and some of the work that we've been doing. Next, I just realized we're missing an M in there, but sorry about that. So first off, with hepatitis B, there is definitely a great disparity in terms of who in the US has hepatitis B. So it is about 50% of the US hepatitis B burden actually falls on the AAPIs, or Asian American and Pacific Islanders. And we have infection rates along with African communities between 5 to 15%, depending on what country of origin we're talking about. So while the national hepatitis B prevalence is low at about 0.3, 0.4%, when you start looking at communities where people have immigrated from Asian, African, or areas that are endemic, you see those rates much higher. And a recent CDC surveillance report showed that AAPIs experienced the highest Hep B related mortality rate, so 5.3 times higher. And I think a lot of what's already been discussed in terms of issues with accessing care, I think really plays into that. So it kind of doubles the disparity issues, right? It's not just about finding out whether you have Hep B, but whether or not you can actually get care and prevent the sequelae like cirrhosis and liver cancer. So this is an important issue to address. Next. So minority populations do face even more barriers to access and care. I mean, on the whole, we believe there are an estimated 2 million Americans living with chronic hepatitis B, and sadly, only a quarter are aware of their infection, and only 10% are actually accessing care and treatment. So even in a high resource country like the US, there's a huge disparity in terms of the number of people who actually know about their infection. And when you look at this globally, it's even lower. It's only 10% of people in the world who actually know about their infection. So there's quite a lot of work we still need to do with awareness building. So I think, the more we have events like this and bring in people who, who might be doing other kind of work, it's really important for people to be aware of that. So, so among those who are diagnosed, less than 50% are actually accessing sustainable care, and 20% are receiving prescription medicine. And of course, not everybody who has Hep B needs medication, but you have to at least get in care to be assessed, to get your viral loads, see your liver enzymes, so that you know whether or not you need medication. So unfortunately, Hep B screening is not routinely being conducted amongst most healthcare systems in the US. The current CDC recommendations and USPSTF recommendations are risk-based. There's been a lot of push and discussion about whether or not we should be considering a universal one-time test rather than doing a risk assessment, because the risk assessment is obviously missing a lot of people who need to be screened. Also, because Hep B is a vaccine preventable disease, which is great news, we do see big gaps. While a lot of children and infants, we're doing really well with vaccinating those populations, only a quarter of adults are currently vaccinated. And so there are a lot of challenges there. We're very happy to see that CDC updated their guidelines. So now it's a universal recommendation that all adults should have Hep B vaccines. So we hope that will help bridge that gap. Next. So just showing, because of all the disparities, it's really important that we do have strong community work, and Hep B United is a national coalition of local coalitions, and the work that's been done there to bring together people who are working on the ground with communities is really important way of fighting and addressing the disparities. We have obviously on the federal level and state level, we've got some great policies, but in order to reach those who really need this the most, you've got to have on the ground community who are people who are like the ones who are basically amongst the community, helping to deliver the message and deliver care. So Hep B United is this national coalition dedicated to reducing the health disparities associated with Hep B by increasing awareness, screening, vaccination, and linkage to care for high-risk communities across the US. Next. So, and these are the goals: to raise the profile of Hep B and liver cancer as an urgent public health priority, increase Hep B testing and vaccination, particularly among AAPIs and other communities at higher risk. And finally, to actually provide intervention. So by improving access to care and treatment for individuals living with hepatitis B, we hope to prevent end-stage liver disease and liver cancer. Next. So my practice, I'm actually a primary care physician. We have a Center for Asian Health. We are actually a hospital-based practice, as in a hospital employed, but we do work in the community. And so a lot of our work has been actually to do outreach into the community and provide hepatitis B testing, education. I'm in a practice of all primary care doctors. We actually provide care and treatment for people living with hepatitis B. We have bilingual staff, Chinese, Korean, Taiwanese. And we've done a number of thing community events. We actually had a CDC grant for about 3 years doing screening in foreign-born populations. One thing I want to say is that a lot of the work we did actually relied on partnerships. So I see there's a lot of health departments here, and we actually really relied on health departments. We did a couple talks for some of the local health department consortiums, and New Jersey is unique in that we have a different health department for every town. I think we have like 200 health departments in our state. And what was interesting is that we would be able to coordinate with towns that knew that they had a high Asian population. They would invite us to go to their health fairs that they would have. And so we've developed this great partnership with them. And so I encourage people, your health department, if you recognize that within your jurisdiction, there's a high Asian or immigrant population, that it's a good opportunity for you to reach out to maybe local healthcare providers that are seeing those patients, or maybe at FQHC, because I think that's a good recipe for success. And you can see that a lot of times you have to embed hepatitis B care amongst other care. So people may not come out or just do a Hep B screening, but they may actually do it as part of education they may show up for an event that has more generalized health information. So we would do a Chinese Wellness Day every year and talk about other things. So you see here, we have something about osteoporosis and mental health and, cardiac disease, cancer. And if you build that in the middle, we have Hep B in Asians. And we provided a screening there too. So it's really part of a whole person type care to be able to embed that in. And I think that's really important to think about integration opportunities for hepatitis B in order to address health disparities. All right, next. And finally, one of the programs that we're doing, which has really helped integrate hepatitis screening also, is automated EMR-based screening in hospitals and emergency departments. So we've been able to program our EMR to start identifying people who were born in a country where Hep B is endemic, and it totally happens in the background where the alert will fire and we notify the the staff and the patient, and we do this testing. We have a navigator who notifies patients and educates them about their diagnosis and provides direct linkage to care into our practice or into a facility that is maybe either closer to them or covered by their insurance. So this has been interesting, and I'll show you the next slide actually has the country breakdown of people who've been able to reach. And I think if you live in an area that's actually quite diverse, this is important to be able to, I mean, what you find out is the healthcare institutions end up serving these diverse populations. Next slide, please. Oh, wait, was there not another one?
No, I don't think there was, Sue.
Okay, well, anyway, the slide that I thought I had in there basically shows the demographics of all the people we've served throughout this and the infection rate. And we were blown away. I think for most of our healthcare facilities, we are identifying race. So we may look at who's Black, who's Asian, who's Caucasian and Hispanic, but we don't necessarily know what countries they come from. So you could be Black from the US, Black from Africa, Black from the Caribbean. And when we started collecting the country of origin data, we could see, wow, we had no idea we had so many Haitians. That's like the #1 country of origin of patients outside of people born in the US that we were serving. And we would have not known if we hadn't started capturing that country of origin data. And when I looked at the diversity of the people we served in our emergency room, I thought, you know, that would take so many health fairs for me able to go to, you know, the Ugandan church or the Nigerian church or the Chinese, you know, temple. But just if I could, the fact that we were able to do our emergency room, everybody's coming to us. It's a great opportunity to actually screen quite a diverse population. So I think there are a lot of opportunities out there if we just, you know, work with our existing organizations to try to do that. And I have to say our hospital loves it too, because it's a way of addressing diversity and inclusion, right? Everybody wants to do a good job with D&I and also community, you know, kind of meeting the community needs in your area. So challenge people to consider opportunities like that. All right, thanks. Back to you, Michaela.
Thanks, Dr. Wong. I'm actually gonna stop sharing and turn it over to Chioma to share her slides.
Great, thank you very much. Good afternoon, everybody. Thank you for having me here. My name is Chioma Inaiji. I'm a senior program director at the Multicultural AIDS Coalition, which is a nonprofit organization, HIV/AIDS organization in Boston, Massachusetts. And so I'll be talking a little bit about our experience, our work around African immigrant communities around hepatitis. A couple of the other presenters have already sort of talked about hepatitis or mentioned hepatitis as it relates to African immigrant communities. But what we do know that we're seeing high rates of hepatitis B on the continent of Africa, which translates to infection rates here in the US, where we see up to 15% infection rates in some African immigrant communities. Screening is low. Part of the reason why screening is low is because there's limited understanding and awareness around hepatitis B and how it leads to other diseases within the community. And there's been sort of recent work on sort of understanding what are those barriers and how culture and religious beliefs play a role in people's perception and their engagement in hepatitis B care and treatment. And similar to a lot of other diseases that I particularly work on, such as HIV, hepatitis B is very stigmatized because of transmission, the way that hepatitis B is transmitted. And also, again, because people don't have an overarching awareness about the disease. Most times, a recent article came out where in New York, they did an epi study and found that a lot of populations or clients with hepatitis B were presenting at late stages of liver cancer and thus died within months of diagnosis. And overall, systemically, we see that there is a lack of appropriate hepatitis B surveillance. The previous presenter talked about country country of origin. The HIV field has done a fairly good, taking a very good stance on ensuring that that country of origin is a part of surveillance data in several states, but we haven't seen that push in hepatitis B surveillance data. So we don't know. We really don't know what the epidemic looks like. And then there's a lack of culturally and linguistically appropriate education and services for this population. And so since this panel is really about health equity, I really want to couch it in sort of what do we mean by health equity? And when we think about health equity, we have to think about two things. One, that structural barriers are experienced by individuals, and it's the structural barriers that really prevent individuals from engaging in services, whether that's screening, care, or treatment. The other thing is that we have to understand that people are operating with multiple overlapping identities, right? And these social identities are often put on a hierarchy where some are at advantage and some are at a disadvantage. And that is what places people at higher risk or have higher mortality and morbidity versus sort of the fact that person holds X, Y, and Z identity, right? It's really the way in which it is framed within a more social hierarchy that makes it problematic. So I always like talking about intersectionality as part of our conversations around health equity. I think we have in public health, we're getting into intersectionality and understanding it with some work that Dr. Lisa Boleg is doing, but we really haven't fully understood it and applied it into practice and research. And so intersectionality actually was coined by Professor Kimberly Crenshaw. You can look up a lot of her work, and it really focuses on systems of oppression and power and privilege. Unfortunately, it has become a trend, and so a lot of folks are just saying, like, it's sort of like, how many identities do you hold? I have 6, I have 8, but that's not what intersectionality is. Intersectionality is understanding how your social identities really play a role in you being marginalized, right? And how that becomes compounding and makes you more vulnerable to various diseases or illnesses such as hepatitis B. There's a historical and current sort of understanding of intersectionality and the role it plays within our health system and within society. So we can't talk about what's happening today if we don't look at and understand what has happened in the past to bring us forward, right? And it's constantly being produced and reproduced, right? So it's like this vicious cycle, right? You hold a certain identity, it creates a certain vulnerability. That vulnerability leads you to being stigmatized. It leads you to not accessing services. And there's a difficult way, there's difficult ways in which to intervene in that cycle, right? And, we all hold various social identities like race, gender, nationality, sexuality, and occupation. And so I want to talk about what does intersectionality mean in terms of African immigrant refugees and hepatitis, right? And so when I talk about African immigrants and thinking about intersectionality and social identities and oppression, I really focus on sort of these 3 social identity categories. We can add a whole list, all right? We have African immigrants who are part of the LGBTQ community. We have African immigrants that have disabilities. So we can add to the list, but when we talk about the commonality around this community, it's around these sort of 5 areas: race, nativity, immigration status, ethnicity, and language. And you see in the next column, what are the sort of societal oppressions or structural oppressions that are in play to prevent individuals from being able to access these services, right? So it's not about individual behavior. It's really about how systems are set up in a certain way where people don't even have the opportunity, right, to access these services and really to take care of themselves. So some of the social oppressions that are overlapping and intersecting for African immigrants are anti-Black racism, which is similar to what US-born Blacks deal with on a day-to-day basis. Nativism, which is sort of the fear of xenophobia, is the fear of something that is foreign, the fear that someone has a different sort of nationality, right, than being US born. Immigration status, we know how that plays around. Immigration is a social determinant of health, so we understand how immigration status, because the way it's set up here in the US, can be a way in which people are targeted or people are not given access to certain services. And then ethnicity, right? right? Understanding African country of origin. I think that's very important. A lot of folks think that once immigrants come here, they sort of leave everything behind, right? Like we're no longer that person, or we no longer hold that culture. But it's important for us to think about how African immigrants, what's happening in their home countries around some of these issues, are playing a role here in the US and them engaging in care. And then language. Linguistic oppression has been, I think, one of the biggest areas that we need to be working on as it relates to African immigrants. A lot of African dialects and languages are not part of mainstream, right? Even on the local level, where health departments are not providing information maybe in Somali, or not providing information in Kiswahili, when they know that those communities are some of the bigger African communities that might be in the local area. And so when we look at how these social identities intersect, we're talking about stigma. We're talking about state-sanctioned violence, right? Because of race or because of immigration status. We're talking about targeted racialized criminalization, right? African immigrants have to deal with not only law enforcement, but also immigration ICE, right? Economic instability, because with certain immigration status, you're not able to work, right? Or you have to put your life on the line in order to work, right? And so that puts people in an unstable environment. Linguistic discordance as it relates to engaging with a health provider. And because of their immigration status or because of language, they might be denied or have limited health cover and lack of access to resources. And so I like to sort of show that once we have an understanding on what sort of these intersecting oppressions are, and then we add a disease to it, that's what leads to people not being able to engage. And that's what leads to these negative health outcomes that we're talking about and these inequities that we're talking about. And so we don't want to start from the fact that people are delayed in engagement in care, are not getting screened, or are having poor communication with their sexual partners. We want to start from what are the underlying issues that put people in a position where they are engaging in or having to deal with these individual behaviors. So there has become nationally some work happening on how do we actually start addressing hepatitis within African immigrant communities. And that work has been some coalition work. That work has included also some work on making sure that we have at least culturally appropriate educational material, which is coming out of Hepatitis B Foundation. But myself, Hepatitis B Foundation and CHIPO have been working I would say for the past 10 years on trying to get National African Immigrant Refugee HIV/AIDS and Hepatitis Awareness Day federally recognized. In a lot of our work, we know the importance of federally recognized awareness days. We know what can happen. One, it brings visibility, and two, it can bring resources, right? And often it comes from a community, a grounded approach. And so really the resources are grounded or get to community-based organizations or are seeing these issues every day. And so we want to continue to work on getting NIRA Day federally recognized. The day is September 9th. We've been doing celebrations. We've been doing all kind of work on September 9th in the month of September to keep NIRA Day sort of in the forefront. And so really needing to work with federal partners, work with state and city partners to make sure that this day becomes recognized. Now we put HIV and hepatitis together because these are diseases and illnesses that have some of the similar sort of transmission ways to transmit, stigma, and they have a lot of similarities, and that both of them are not being acknowledged or not being directly addressed within the community. So that's why we put it together. So you'll see what the goal of NIRA Day is: raise awareness, support communities in learning more about how to protect themselves, ensuring that communities are able to take control of their health, right? So that health becomes the default, and then getting our policies and practices aligned with ensuring that our communities are healthy. So there's information there on NIRA Day. So I ask that you connect with us, and also you help us think about what are the ways in which we can make this happen, so that across the U.S. we're really addressing this issue. So I'm going to end. Thank you for having me, and I look forward to questions at the end.
Aloha, everyone, from the beautiful state of Hawaii. My name is Josie Howard, and I am the CEO for a newly established nonprofit called We Are Oceania. I'm originally from Chuuk. This is my grandmother's island in my background. And I've been living in Hawaii for more than half of my life. I'm not here as an expert, as a hepatitis expert. My participation is really as a storyteller and a learner. I'm learning a lot. I'm not involved in any hepatitis work here in Hawaii, but it is something that it's on my radar, as it is an emerging urgency for our community. So We Are Oceania serves the Micronesian population. So the Pacific Island population that I'll speak more to it is the Micronesians. And I'll start out with sharing my story of hepatitis, where I come from. But maybe before I can do that, I'll give you a picture of where Micronesia is and how Micronesia is. Micronesia is literally means small islands. So there are many small islands in Chuuk, where I come from. There are about 40 municipalities, but separated by the ocean. And so we spread out like by maybe 300 miles by ocean. And you can only reach these islands by boat or a ship. And that will take you about a day and a night to get out to these islands. And when I was living there, the ship will come twice a year. And it's called student rounds, to come pick up students and take them to the main island where the high school is, or where we can get higher education. And with that round, they also bring out the health workers. And so I remember taking vaccines. And that's when I first started to hear about hepatitis. People were taking vaccine for this disease. However, it wasn't really something that it was an urgency or people were talking about. When AIDS came out and everybody became aware of it, I can compare that there were more urgency and education on AIDS than hepatitis. Anyways, I'm also someone that grew up with families that had hepatitis, but we hardly talk about it. We just treat it as one of the sickness or one of the disease that one gets. I think in the history, we can all relate to that as Pacific Islanders, where this infectious diseases were not in our communities until we got discovered by outsiders. These islands are so isolated in the ocean that one will think that they would not get exposed, but we did, and we're living with that. Now moving to Hawaii, it's the same thing. Like one of the biggest barrier for our community to learn more about hepatitis, I think there's very little awareness on hepatitis, and one of the biggest barrier is language. A lot of people don't really understand because they don't understand the language. So one of the role for my organization is to help, bridge these gaps of our people learning, new things, including hepatitis. But still yet, I remember like when I first started working in, the social service area, I had someone who used to bug me about, Josie, I need you to help me to help educate your people on hepatitis. And I used to look at him like, that's not our urgency. So it is really like about also urgency. So when we move or migrate out, our first urgency is acculturation. We need to learn how to fit into this new world, learn how to survive. And our first survival urgency is to find a job, to be able to have a home, to be able to have food, and to be able to send your kids to school. A lot of Micronesians here in Hawaii, they also come for healthcare. So one of the urgencies is to be able to have health coverage and to be able to, access the healthcare here. And as you all know, that we had some challenges in getting adequate healthcare. And we still, we just got Medicaid restored, but there are still steps, ahead of us to fully help our community. And I think when I listen to everyone's presentation, I feel like, oh my gosh, we're like so behind. We're so behind. And I can relate to the last person who just spoke, about the story in Africa, because that's basically the same thing with our community here in Hawaii. But when COVID hit, it really brought forward our disparity, not just as Micronesians, but all Pacific Islanders. And we saw how this illness got intensified, or people were prone to die from COVID because we had other underlying medical conditions, and these were some of the underlying medical conditions. For me personally, I started to see more families suffered from hepatitis. And I feel like, if only we're educated on it, there's so much service now that we could get early treatment to, avoid early deaths. People are dying young because of hepatitis. I was really, I learned so much in one of our focus group with other Pacific Islander leaders when we talk about hepatitis and the priority of, our needs. And almost everyone felt that hepatitis is not a priority in our community. And I spoke up because I think hepatitis is a priority in our community. And I really want to learn more about it. I want my organization to get involved in educating our community in the language so that, the information can get out. So that is why I'm here. I'm sorry, I'm not a hepatitis expert, but I can bring the stories of people who, and a community who is struggling with hepatitis. Thank you so much.
All right. Hi, y'all. Good afternoon. Thank you for having me to wrap up presentations for this panel. My name is Christine Rodriguez. I'm the Senior Program Manager for Harm Reduction at AIDS United, overseeing our strategic grant making and technical assistance portfolio related to drug user health. It's a real pleasure to be here today to spotlight communities of people who use drugs in this conversation about health equity. So to keep to my time, I'm just going to go over some quick basics today so that we can get to questions and discussion. Next slide, please. So walking through A, B, and C, right? As these stats show, where risk factor information is available, there's a significant incidence of both Hep A and Hep B among people who use drugs, people who inject drugs in particular. And when we think about sort of the universe of folks who inject drugs, a recent estimate put past year injection drug use at about 1 million people, right? So we're talking about pretty high infection rates among these communities. One of the grant making projects that we're working on at AIDS United in collaboration with NASTAD and supported by CDC is really focused on integrating COVID-19 and other adult vaccination into syringe service programs around the country, including vaccination for hepatitis A and hepatitis B. Vaccination access is really incredibly critical for folks who use drugs. We've seen a number of outbreaks across the country of hepatitis A in particular among people who use drugs and those experiencing homelessness. So in terms of service provision, syringe service programs are ideally situated and really have the relationships with folks built on trust and respect, right, and compassion. And we're really looking forward to sharing lessons learned and best practices from our grantees within that project to support increasing sort of this really, really important access to vaccination for folks who use drugs and folks who inject drugs in particular. Next slide. Hepatitis C, as y'all already know, right, the most common bloodborne infection in the United States. And among cases where risk factor information is available, 67% of incidents in 2019 reported injection drug use, which is the primary risk factor still for hepatitis C transmission. Prevalence really varies, right? Depends on the community of folks who inject drugs and can vary pretty widely depending on a couple factors. but is estimated to be as high as 70% within some communities of folks who inject drugs. And given high prevalence, it's also estimated that nearly a third of people who inject will acquire hepatitis C within 1 year of starting to inject, right? So we really want to highlight this and focus on our communities of folks who are using, not just injecting, but particularly those who do inject as being really, really vulnerable to transmission for hepatitis C. And many of whom have been injecting a long time, who have been living with hepatitis C for many, many years and really deserve access to treatment and care and cure now that we have those incredible medications available. Next slide, please. As a bloodborne virus, particularly Hep C, that remains really sturdy outside the body, sharing drug use equipment really presents a number of opportunities for transmission. Sort of wherever blood is found, there is some opportunity, right? If you're sharing equipment for injecting in particular, but there's also evidence around transmission, around sharing smoking supplies, in particular from studies around sharing pipes for smoking crack. The same sort of intuitive risk exists for sharing snorting supplies. This can make us really dry, really create sort of little cuts inside your nose where there is an opportunity for sort of bloodborne virus transmission. And so making sterile supplies really widely, freely available to folks who use drugs across routes of transmission, whether folks are injecting, snorting, smoking, whatever the case may be, is really critical for prevention. Folks who are on this call might be aware of the sort of big press sort of panic around distributing pipes for smoking crack in particular that happened recently a few weeks ago in the news. And I feel like it was an unfortunate missed opportunity for a really important conversation around the role that sterile smoking supplies can play in prevention of infectious disease transmission, like Hep C, like HIV, and really would have been wonderful if we had $30 million just for crack pipes, but that's not the case. And unfortunately, that opportunity seems to be closing off for us as that sort of panic and a lot of racist rhetoric around that panic sort of spreads. Next slide, please. Just wanted to shine a light on syringe services programs, in particular around prevention of all of these hepatitides. And thank you to the syringe service providers who are on the call. I know I saw a few. In terms of prevention and providing those sterile supplies, it's so important for us to support the implementation and success of our syringe services programs around the country, which historically have focused on injection supplies, but many provide an array of services for those who smoke or those who snort, many of which provide linkages to care for HIV, for hepatitis, for substance use disorder treatment, for primary care, mental health care, social services, et cetera. So these are incredible resources in our communities, despite often being misunderstood or stigmatized themselves. SSPs are associated with about a 50% reduction in HIV and Hep C incidence, with that number jumping to about 2/3 when combined with access to medication for opioid use disorder like methadone and buprenorphine, when folks can stabilize a little bit and maybe find an avenue to reduce how often they're injecting. In particular, that just creates more opportunity for prevention and fewer opportunities for transmission. I also just wanted to highlight treatment. Treatment is really important as treatment and as also prevention for sort of forward transmission for people with either current or past drug use experience. This is a really critical health equity issue, I think, with folks often having been told to wait for years, for decades, or being denied treatment, particularly prior to the introduction of direct antiviral medication, but also as it was introduced into our healthcare system. There is still really, really significant stigma, certainly a lot of barriers to access, but I think we've seen a really important shift toward opening treatment access for folks who use drugs, in large part thanks to advocates like yourselves and events like this that really spread awareness and are able to take some of this information and share it with your representatives on the Hill. So it's just really important, I think, for not only policymaker, but provider awareness that active drug use has not for a long time now been a contraindication for treatment. Folks who actively use drugs, it's very important for people to be treated and cured of their hepatitis C. So really important to dispel those notions among providers that may hold stigmatizing beliefs about folks who use drugs or folks who inject drugs in particular. I will always remember a story from a program that I worked with out in San Francisco that is phenomenal, a syringe service program working to connect folks to Hep C care and cure. They were able to utilize sort of street medicine to get a woman who's experiencing homelessness tested. She had hepatitis C, she was connected to care, and within a few weeks, she realized that the immense fatigue that she was feeling, she thought was from sleeping rough. It turns out the majority of that fatigue was from her hepatitis C, and she was able to make a change in her life by her own volition, her own interest and choice, to stop shooting methamphetamine every day because she didn't need all of that energy to sort of deal with the fatigue and the side effects of her hepatitis C. And so really connecting folks who use drugs to care can make enormous changes and can make an enormous impact for folks who often are just denied care and treated with enormous disrespect and often violence by our healthcare and other systems. So I will go ahead and end there so we can move to questions and discussion. Really appreciate y'all having me today, and thank you.
Well, thank you so much to all of our panelists. I think we have a really great discussion with just learning more about each community and seeing how they're so different, but they all intersect and they all face similar barriers. And I think we can all agree that there's plenty of solutions out there, but we do need the resources and we need to work together in order to find them. So I have one more poll for you guys. I just launched it. You can ignore the one on the slide. But I did want to talk about the role of the federal agencies in helping us to achieve some of the solutions that we proposed today. So just apart from the federal agencies that are present today, so we do have the Office of Minority Health, and we have the Office of Infectious Diseases and HIV/AIDS policy. What are some more agencies or divisions of federal agencies that we think would be helpful in helping to reduce these barriers and challenges to access and care for the viral hepatitis community? I think one of the main lessons that we learned today is just working together and making sure that we're all on the same page is going to be the best way to tackle these issues. So kind of bringing everybody together in one room or one virtual space is really key part of that. So I'm really happy that you guys are here today. And if you guys have any other suggestions, please feel free to drop them in the chat as well. If you see an agency or a division here that you think we should be more engaged with. So I think we can end the poll there. And let me share the results with you. So first one, I think kind of goes hand in hand with what we were seeing with the first question, that we see a lot of health insurance and cost barriers. CMS by 76%. I think we're all looking to engage them a little bit more, as well as the Health Resources and Services Administration. So we definitely have a lot of room, and as we move forward with the appropriation season, working more with federal agencies, we can keep this in mind. So now I'm going to turn it over to our discussion. We got a lot of great questions in the chat. Please feel free to add more as they come in. But I'm going to start with a question that I think kind of touched all of our presentations today and is really key to the health equity discussion. So we heard a lot about how racism and stigma impact the ability to access care for our communities. And we know, and we heard that it's both on the micro and macro levels that our communities are facing these issues. So one thing that I would like the panelists to think about is, if you haven't already discussed how it impacts your community's abilities to access viral hepatitis care, that would be great to hear about how racism and stigma interact with your communities. But also, we hear a lot from the communities about how internal biases from providers might impact a person's ability to feel comfortable coming forward and talking about any risk factors or getting help and treatment within their communities as well. So could you talk a little bit about how we might be able to overcome internal bias as well within the community for health workers? And I can turn it over to the panelists for that.
I'll start. I think it's definitely important to address implicit bias and biases healthcare providers have. And it's good that this is getting a lot more discussion now and awareness at our healthcare institution. They started requiring training for this, and it's just eye-opening for all of us, to start realizing that we have these biases. So I think it's good when it's done as a larger effort, not just like even singling, people with hepatitis. So I think wherever you work, you can always kind of encourage that kind of training. There's so much of it available now, more than even, just a couple of years ago. But it is something I think as providers, as a clinician myself, we don't even realize what patients face to even make the appointment, even get in the door to see us. Like, I think people who have English as a second language, like, even just making the appointment, sometimes people are just rude to them and, treat them, look down on them. And I think, we don't recognize that sometimes. So sometimes it becomes like, for us as a provider, like, oh, you're non-compliant, why can't you just get over here? Why can't you just do the blood work? And we don't realize like what patients face. So this is why, if you can find a provider or a healthcare facility that, obviously does a really good job serving that community, I think that's one of the major reasons people do so well, right? I think there's an affinity when there's a lot of talk now about like provider patient, not having discordance, but, if they're of the same race or background, right? There's just a natural connection. And I think those are, really real things that come up. So it's good to discuss. And I think, Chioma, you were about to say something too, so pass it on to you.
Yeah, thank you. I think definitely. Oh, Josie, go ahead.
No, go ahead.
Okay, I think definitely training is one strategy that has shown to sort of move the needle forward. I also think that, we need to really look at how our providers are being educated and socialized. And so in talking with some of my colleagues who are medical providers, either sort of doctors or nurses, really understanding sort of the kind of education that they do not receive. And it could be as simple as, what does the mannequin look like that they're working on, right? Understanding different skin types, or even how do you work around skin tones, maybe around certain screenings that need to happen. So I think our medical education, or the way that we're educating some of our providers, physicians, nurses, and probably, social workers all down the line, we need to really look at that and really think about how we socializing providers to only look at our patients through a certain lens, whether that's the lens of whether that's a lens of a particular race, majority race, white folks, or whether that's a lens of a particular social economic status, whatever that lens is, what are the case studies that people are being sort of educated, are being used in our education system? Like I said, what are some of the mannequins that are being used? So I think that's where we need to start. And then definitely sort of build on that in terms of two areas for me. One is providers need to be held accountable. I think too often patients complain, too often colleagues and peers complain about a particular individual, and that individual is allowed to continue to do and behave the way that they behave towards certain clients because of various, social identities. So I think our systems, community health centers, hospitals need to start really holding providers accountable when a complaint is made and take it seriously. Just like we have upped the game on sexual assault within the workplace, we need to up the game on some of the other ways in which people are being harmed by providers all around the line. The last thing I'll share is we need to address the lack of tracking, the lack of amplifying people's differences within our tracking systems, right? And so in our electronic medical records, it seems like often there's more of a shift of trying to, for lack of a better word, erase all these differences, right? Because it's easier, right? And we can't have too many indicators. The provider can't ask all these questions, all the ways in which we excuse the fact that we can't even capture the beautiful uniqueness and differences of our patients in the medical records, because we know all of that matters when we're trying to provide care for individuals, right? So even the way in which we are holding people's medical records and the information that we're keeping, I think definitely needs to be a 360, a whole sort of transformation around all those three pieces that I mentioned. So Josie, please share your thoughts.
Yeah, I just wanted to add, I think everyone had covered really, great ideas. And in addition to, like the fact that we all have biases, it's also what our organization have done here in Hawaii is to provide resources to educate the service providers to know who we are as people, our culture, our religion, our beliefs, because those matters. And it really helped when we work together. We come in and we do the training on, who we are, the sense of people, our geography and our history. Sorry, my background is noisy. And our cultural values and our need here in America. And recommendations on how we work together. So I think also being able to know resources that are out there to help bridge this gap, so that service providers will become more aware and know who the people they're serving.
Thank you, guys. I think that's really. Oh, sorry.
Yeah, if I could just jump in, I think all that I would add, when I think about sort of racism and stigma for our communities intersecting with healthcare access, it is sort of very layered, I think, for our communities, given the immense stigma around drug use and the sort of hierarchy of drug use, insofar as injection is the most stigmatized type of drug use. And it's sort of impossible to talk about how racism interacts without acknowledging the war on drugs and the racist implementation of our drug laws. If your sort of risk factor for a given condition like hepatitis is criminalized, I saw some folks in the chat that I know are from Indiana where syringe possession is a felony, right? There is no incentive to share that with your healthcare provider, and a criminalized activity stigmatizes you just sort of like off top, right? Just baseline stigmatized, right? So healthcare providers, I think, we've discussed sort of medical education, and I think really getting some training and getting some experience and understanding with people who use drugs, who are often thought of as really not caring about their own health or the health of their loved ones, which is an absolute falsehood. And so working on, sort of provider attitudes, of course, but, like Annette is saying in the chat, decriminalization absolutely is a public health strategy. and decriminalizing, not only the use of drugs, the possession of them, but the paraphernalia associated with using drugs is essential if we want people to be honest about their health needs and their risks. And all of that is sort of wrapped up in this whole sort of mess that is this racist drug war.
Yeah. So I just want to jump in and just provide some thoughts, just piggyback off of what everyone else has said, but systemic racism is just a wicked, wicked problem that it's been around for a long time. And I think every single person in this country has to evaluate kind of where they stand and their positionality, because it's not just medical providers. I know we tend to focus on medical providers because they are providing that direct care, but at every level of that social ecological model, racism is really and truly integrated, at the individual level, organizations, providers, education systems. And so to address it, it has to be a systems approach. We can't just solely focus on medical providers and the education system. We have to find ways to integrate the different systems to address this wicked problem. And again, in terms of training providers, I think I certainly agree with that. But again, how do we train providers in a way where we're also bringing in various parts of the system so that providers understand how their role in other parts of the system, at some point, policymakers, right, they need to be educated on racism. They have to evaluate and be pushed to look at kind of where they stand on this. They ultimately make these decisions and roll out these policies that trickle down and impact those of us in federal positions. We have to understand the role of federal government, the history of federal government in perpetuating disparities and inequities, and how, as feds, what do we do in our roles and in our position to redirect and to make change. And so I think that at every level and every parts of the system, no matter where you sit, you play a role in addressing racism and how it impacts care for patients. And you have to do the work. It's hard work because it is a wicked problem. And you have to do the work to help bring the various systems together.
I think that was really well said, Lucy, and it definitely brings us into a great next question, but this is definitely a system level issue. And one of the things that Jessica talked about from the federal perspective was that we are working on a syndemic approach from the federal level. And so while we have a lot of these different groups, like we talked about HIV, Hep C, Hep B, they're all sort of their own communities within the project community, right? So I was wondering, when we say syndemic approach, what exactly does that mean? And how can communities incorporate this approach more into the work that they're doing or into their activities?
I can start. I already discussed it during my presentation, but I want to add, in addition to HIV, viral hepatitis, STIs, and substance use disorders, and those agencies that work in those fields, we're also bringing in other agencies like Department of Labor, Equal Employment Opportunity Commission, Housing, HUD, Department of Justice into the conversation to address other areas of intersecting social determinants of health. So I think a lot of providers are already addressing whole person care. There's already a lot of great examples occurring, but that's not happening everywhere. So like in behavioral health or harm reduction settings, how can we bring viral hepatitis services into those areas, or in HIV or STI clinics? So I think syndemic can mean, at the federal level, we want to bring in all of these voices, but it can also mean, how can we just bring in additional services in other areas?
I think that's a really good way to put it. Oh, sorry, were you about to say something, Christine?
No, I just, I think from sort of our context, when we think about syndemics, we think about sort of the interaction of HIV, viral hepatitis, and overdose, and the way that these sort of three epidemics interact, exacerbate the other. And it just, I feel like so much of it points back to stigma and not sort of treating people who use drugs as sort of vectors of disease, and not having a disease focus, but, you know, like just focus, and having that that holistic care focus apply to people who use drugs as well, and building out sort of options, but also resourcing the infrastructure that works for people who use drugs, that meets them physically and in other ways where they're at, building out the capacity of Syringe services programs to incorporate other services like hepatitis services or STI services or HIV services, because there's a lot of expertise, particularly among folks who use drugs, to be able to serve each other. And I think taking that sort of that drug user health broader holistic lens is really important in our context as well. And sometimes I think gets forgotten, but really appreciate the sort of whole person perspective of a syndemic approach to treating hepatitis.
Yeah, it's a really great way to put it. The communities are experts on their needs and what resources that they need. So they definitely cannot be forgotten when we're talking about these larger communities and bringing in everybody together. They need to be at the table too. And I wanted to note, we had there's a great conversation going on in the chat for you guys as well, and in the Q&A box, a few of our panelists have answered questions directly. So I do encourage you to look there. But in terms of the syndemic approach, Roxanne mentioned that making sure screening and treatment become a standard identifier, and quality metrics like HTN and diabetics control is also something that might be considered. So I think that's also a good point when we're talking about system level, and we talked a little bit, Dr. Wong talked a little bit about EHR systems. Those are part of the system as well, and making sure that we're kind of making sure everything's on the same page and as comprehensive as possible to address these needs is a really key part. So we have a question from the panel, I'm sorry, one of the participants. I'm gonna let her speak so you guys can hear her question. Nadine, can you talk?
Oh, hello.
Hi.
I didn't expect to be called on to thank God I can read it. What I found on the subject of HBV is that I believe, this is just my personal belief after years of thinking on this, I believe we need to confront the role of internalized oppression that I continue to run up against in all levels within our foreign-born communities. And I'm talking about people who've lived here a long time, 5, 6, 7 generations, and as well as those who've just arrived. But I'm speaking also of those who already have standing and an ability to expose it and help our communities move beyond it. Because even as we work with HBV, many of us think, okay, what about the potential backlash? Look at what happened to COVID. Are we going to have that to deal with too within our community? And I found that what has happened is that it's created layer upon layer of silence within the communities. Even those who know and speak of health disparity and all have never called it out for what it was. No one seems to be willing. And I'm wondering if there's a way, and if anyone else thinks that it's necessary for us to do it system-wide within our own communities, that we get beyond this and get people to say, this is it's a health issue. and you know, but the reality, knowing full well that we still deal with racism, with anti-immigrant sentiments, anti anybody who doesn't look like they were meant to be here in someone's eyes. I'd like to know what the panelists think, because I think for myself, I believe it's an important part of our really moving ahead and accelerating the elimination of HPV. Sorry it's so long.
Hi, thanks, Nadine. I'll just be very quick. I think internalized oppression, I have a little mixed feelings with it, because again, I think racism that's one of the results, I guess, is that the word, of racism, right? It's making
Exactly.
you know, so ultimately it goes back to systematic and systemic racism that continues to make a certain population feel oppressed, right? Racism continues to be on your back. And so I think certainly agree that communities, you know, some communities do continue to feel oppressed, but back to what Chioma noticed, we have to also think about the underlying cause of that. And it still goes back to a system of power that continues to make a community feel like they can't speak up. What has happened to a community historically when they have tried to speak out on things? You know, I think, you know, again, as you know, a woman of African-American descent, I think about the Martin Luther King. What happened to Martin Luther King when he spoke out, right? He's not here today. And so I think that even with other communities, there's a reason why they feel oppressed. There's a reason why they feel that way. And sure, I think that there's opportunities there to educate the communities and empower the communities, but I still feel very strongly that this is a power imbalance issue that that also needs to be kind of like the larger focus, because I don't think individuals and communities can really get past that if the systems of power don't change.
Yeah, I 100% agree with that. And I think part of the conversation is where are the key interventions? Like, where do we need to intervene, right? Because I think often, you know, I talk a lot about, you know, anti-Black racism. I talk about, you know, racism, and I work with organizations on sort of developing their framing and their practices around it. And you know, when you first start having a conversation, people are like, oh my God, it's so big. like where do we start? And it's so, you know, it's so ingrained in the social fabric of the United States. Like, how can we sort of dismantle it, right? And so, you know, part of our conversation, you know, has to be around where are those points that we can intervene and start moving that needle, right? So it's a big thing, right? And you know, maybe racism won't be, you know, eliminated in my lifetime, but it might be eliminated 2 generations from now, right? And so that's what I need to focus on. What can I do in this moment as an individual connected to a community, as an individual connected to organizations, as an individual that has a level of privilege and power? What can I do to move that needle? And Nadine, just to answer a little bit, I think of what you were sharing with us, I do think part of the question is, how are we making our mental health services more accessible to populations that are really struggling, right? And dealing with sort of this internalized oppression. And it gets back to where we have integrated services. You know, when the initial question came up around multiple pandemics, syndemics, you know, I was thinking about our work at the Multicultural AIDS Coalition. As an HIV organization, we started off doing rapid testing, right? Back in the day when you had the finger prick, right? Wasn't so back in the day, but with the finger prick, right? And I think a huge intervention that happened in the HIV AIDS world was integrated testing. So now not only you know, the same person who's using drugs and the same person who is, you know, at risk for HIV, at risk for hepatitis C, I mean, they're all the same, right? We're talking about all populations that have been marginalized or are vulnerable, right? And so we have them at that point, at that one moment in time. How are we able to provide the services that they need in that one moment, right? So integrated testing, that we test for gonorrhea, syphilis, chlamydia, hepatitis C, and HIV, right? A urine and a blood sample, right? We haven't been able to get to hepatitis B because of testing technologies and testing modalities, right? But we need to get there. How do we integrate? I mean, for a state level, there's a lot of differences across states. We all know that, right? So in Massachusetts, right? So I think it's also about now at that moment in time when we have that individual, and we know that that individual might be struggling with their hepatitis C status or struggling with their HIV status. How are we able to provide them with some type of mental health service, right? That initial, maybe it's that initial assessment that they need to get to, right? It might not be that they're signing up for a therapist and going every month, but that initial assessment so they know, look, this is where the service is, right? So I think it gets back to how we thinking about sort of, you know, we're not creating organizations that do it all, but organizations that can think about when you have that one person, what is all the ways in which that person could be impacted and how can you support that person in a more integrated way?
Thank you.
I want to add a little bit too. I think having an experience growing up in a community with a totally different system and coming to America and also have my share of the experience with my own experience with discrimination and with racism and all that. And then also having the opportunity to be a service provider to make change to this system and come up with, how would I say, innovative ways. This is like everybody said, like it's like so huge. But one thing, if I can make it simple, and I can use an analogy of, you know, when I first came to Hawaii, it was my very first sight of homelessness. I've never known about homelessness in my life until I came to Hawaii. And I was puzzled by that. And I was like, why are there people being displaced and homeless in Hawaii? Until I started learning about the system and I live it. And I started to learn about the Native Hawaiians' experience in their own homeland that I got to understand. And it really came down to one word, and that is inclusion. You know, a system, like I feel like there is a need to honor people. America is made up of such a diverse population. It's based on immigration, right? And this democracy we talk about, I just feel like it's not an inclusive system that we really need to look at it from like inclusiveness, like are we all included in, you know, I don't know, it's a really puzzling experience, and I feel like there's no end to it until the system changes somehow. It needs some changes, and I think at this point, all I can see is people on the ground trying to make changes for themselves. And that's really sad that the system is not seeing the need of the people as a whole, a very diverse, you know, population in the United States. I don't know. So, and when I see going back to the homelessness story, I can see why there's no homelessness on my island, because everyone takes care of each other. Our belief system is about kindness, and it's about treating other person the way you want to be treated and be kind. Sometimes the system does not recognize people, but see people as number. And I think those are the kind of things that we need to start breaking down, to really see people as people, and not just someone on the street, not just someone, you know, that comes into your door. And I know it's funny, but I think it goes back to our values, family values of people. Honor people the way you want to be honored. That's it. If we don't have that, we're never gonna get there.
I think that was really well said, Josie. And thank you so much. I know we're a little bit over time, but thank you so much to all of the panelists for your presentations today, for this great discussion. It was absolutely fantastic. And I think, Josie, you said a really great word, inclusion. Health equity is about inclusion and making sure that the health systems are as inclusive as possible and really meeting communities where they are and servicing their needs. So I really appreciate you saying that. And I just wanted to highlight, as we wrap up this session, thank you so much to everybody for attending the very first session of the Policy and Advocacy Summit. We do have a few other sessions coming up, one for the next 3 weeks, followed by a Hill Day. So those are listed right on the screen. We have hepatitis and maternal and child health coming up next week on March 24th, followed by hepatitis and overdose discussion. And then finally, we're ending with a federal perspectives and congressional advocacy session. And we invite you all to join us for the Hepatitis Appropriations Partnership's Hill Day, which will, we changed the date. It will be on Monday, April 11th. So we hope that you all can attend. And when we send a follow-up email, you will all be receiving registration links as well to the upcoming sessions. And thank you guys so much for being a part of this wonderful discussion. You will be receiving slides as well. And I hope you have a great rest of your day.